Hey, good morning, everyone. Let me know if you can hear me, see me. Hey, good morning. Let me know if you can hear me okay. Set up right. There we go. All right, thank you so much. Hopefully the quiz went okay. Like everyone's in. Everyone did well, or most people did well, so that's good. Or look, it went well, I guess. So, no technical issues I'm aware of. What I mean to say. Let's start about a minute here. All right, so let's go and get started here. All right, here we go. So anyway, so we'll finish up our talk on the urology stuff here, and then we'll move on to OB-GYN. So then we have, actually, let's see here. So we got one more meeting after this, and then we'll have the exam. So just an update, I went ahead and I posted that last prescription assignment. I'm going to make it due the day of the final exam. So just so you have about 2 weeks to do that. So no worries there. If you have questions, let me know. Otherwise, we good to go. Okay. So let us begin. So we're talking about urinary incontinence here. So basically, we're having, we discussed BPH and erectile dysfunction. So some of those meds are going to come up here again that we'll see. They'll kind of be present once more. And then I'm turning my window straight here. But we have incontinence. This is where we're getting that involuntary leakage, including some urgency. You can find sometimes there's more of a frequency component versus an urgency. We can see issues of things like nocturia, and of course there's always like a psychosocial component here where it can lead to depression, self-esteem issues, and things like that. So, and again, if we can keep patients continent for longer, this can also do things like keeping them out of like nursing homes and whatnot, which is generally a good thing here. So we're mainly focusing on everything from the bladder down, so urethra, urethral sphincters, things like that. And we'll see that acetylcholine is really important here in terms of affecting the muscarinic receptors. I'm not going to get really in the weeds in terms of if it's affecting M2 versus M3 receptors. Just know that it's going to be acetylcholine affecting these muscarinic receptors. That's the main thing. Normally what this does when you have the urge to urinate is you're going to see that the acetylcholine will cause the bladder to constrict. So the detrusor muscle in the bladder will start to constrict, and then you'll see that the urethral sphincters will start to open up, right? So that way you can have you can start to void that urine there. So what we're going to see is, in order to treat this, we're going to find something to try to block that. So we're going to try some anticholinergics that can help out with this in some respect here. But normally speaking, in order to maintain continence, you have to have adequate closure pressures. You have two urethral sphincters. One is the proximal one, which is involuntary, so that one is going to be more responsive to acetylcholine, and then the distal sphincter is more voluntary for the most part, so you can kind of decide when to void and when not to. Normally, the bladder should be pretty responsive to increasing in volume. So as you produce more urine, it should relax to allow for more storage. But at a certain point, it's going to get stretched out, and that stretching is what stimulates the urge to void. So what you can find in some cases here for patients that have like chronic retention is that the bladder can become hypertrophied, and it can become like thicker and less compliant, such that smaller volumes are going to start to cause that stretch to occur, and that causes the need to void. So smaller volumes, are going to basically be, or the bladder just can't store that as much volume as it used to. So because of that, it's going to cause that urgency or that frequency that occurs there. So we can try to find some ways to try to help correct that if we can, or try to find some ways to allow for more relaxation of the bladder if possible here. So, and again, this is a pretty complex sort of, reflex pathway here, and which is why you see issues of patients who have, like spinal cord injuries, for instance, have issues with this, because this is something that's coordinated from the CNS down, and so if you have any disruption there, that can lead to a lot of these issues that we're going to run into. So first off, we're going to talk about stress urinary incontinence. This is generally going to be due to urethral underactivity. So this is going to be seen with small amounts of leakage, typically small volumes, seen with like bursts of activity. So whether it be like sneezing or exercise, things like that. Usually this is due to sort of like inadequate closure pressures of those urethral sphincters. You can see this a lot after things like childbirth or pregnancy, where you have especially like vaginal deliveries, you're having some shifting and sort of stretching of different parts of the anatomy. And then you can see with menopause, this is mainly due to a lack of estrogen causing changes in the urothelium. We'll talk about menopause a little bit later on today. And then obesity and aging, you can see this most commonly. If it's in men, it's more often due to like surgery, but it's not super common there. So usually female patients are going to be the ones that are experiencing this stress urinary incontinence. And can be aggravated by medication. So for instance, part of that closure of the urethral sphincters is through the alpha receptors, right? So just like we saw with alpha receptors being important for BPH, there are also some alpha receptors here in the urothelium. And so you can lead to, if you have like an alpha antagonist, for instance, that can relax that smooth muscle and allow for that urge, allow for that leakage to occur there. On the other hand, things like ACE inhibitors and ARBs can cause coughing, which we see here. That brief burst of activity can lead to the leakage, so that can be a problem as well. So you may want to consider switching patients to another antihypertensive if that's necessary. So another type of incontinence we can run into is going to be the urge urinary incontinence. This is typically due to bladder overactivity, and so this is leakage that's associated with a lot of urgency, right? So instead of it being something to where you just you sneeze and you have a little bit of leakage, this is related to actually you're going to have a lot of need to go to the restroom, the urgency associated with it. This is typically due to either the detrusor muscle, or typically is due to the detrusor muscle being overactive, leading to that sort of inappropriate response with smaller volumes of urine here. Or you see these involuntary contractions, and so that leads to smaller volumes triggering that stretch response, leading to the need to void. And so not necessarily the same as an overactive bladder, so this is more related to the urgency aspect of it necessarily than the frequency component to it. And it could be related to idiopathic, so it could just be no specific cause associated with it. A lot of times you can see issues in terms of obstruction leading to this. Long-standing BPH maybe leading to this. You can see other types of bladder outlet obstruction. And can actually be worsened by things like diuretics and alcohol. Alcohol, tends to cause a diuretic sort of effect due to it blocking antidiuretic hormone. Diuretics, obviously, it leads to an increase in urine volume. So that can lead to that stretch response being activated in the bladder there. And then there's your overflow incontinence, which is typically related to sort of a combo in a lot of cases of urethral overactivity and then bladder underactivity. So you can see here that basically the bladder is unable to fully empty, usually due to some obstruction. and they get this chronic urinary retention. And then in some cases, it could be related to urethral hyperactivity, where it's not releasing like it should, which could be related to BPH in a lot of cases, or due to certain neurologic diseases like multiple sclerosis and spinal cord injury. So those abbreviations are there. And if it's a bladder underactivity, this is oftentimes again leading or as a result of that bladder outlet obstruction, like diabetes. It sometimes lead to some neurologic or neuropathic injuries that can lead to this. So kind of it could be one or the other, but usually a little bit of both there. So for the overflow incontinence, we're going to see that there's different ways we can treat this. And so for instance, things that can cause urethral hyperactivity can be things like tricyclic antidepressants here. We see alpha agonists can cause too much of a closure there, so that could lead to the inability to void effectively, right? So that could be aggravating it. And then anything that decreases bladder contractility, so usually antimuscarinic drugs, leads to it not being able to really kind of squeeze as much as it should and be able to get rid of that urine there. So things like antipsychotic drugs, TCAs, anticholinergics, they all have anticholinergic properties there that can lead to that. And then calcium channel blockers just can relax that smooth muscle and lead to those issues as well. So you can see it's always good to look at the medication list to see if that could be aggravating sort of their issues there. So for this, we're going to see that treatment is going to depend on the sort of underlying pathophys. We're going to see here with the urethral underactivity, again, that's associated with leakage with physical exertion. With bladder overactivity, you're going to see this is related to frequency, so how often they're having to go to the restroom, and along with urgency. And then with overflow incontinence, they're going to be experiencing a lot of abdominal fullness. They're not able to really void completely, things like that. So, based on the history and what they're telling you, can sort of help you delineate one versus the other, and that can dictate how we're going to be treating this, as we'll see. So course of therapy is going to really be dependent on what is bothering the patient. So whether it's how often they're having to go to the restroom, perhaps it's disrupting to their normal daily processes. Do they want to use things like absorbent pads or adult diapers? That may be something that's kind of like a no-go for them. So this is really just kind of dependent on what is important to them in a lot of cases. I just want to check on one thing here. So then in terms of treatment, we're going to see we want to get restoration of continence, hopefully reduce the number of incontinent episodes if possible. And then if we can prevent from, complications of things like, them having to be placed in a nursing home, that's always going to be good because elderly patients tend to deteriorate once they get placed into a nursing home to some degree there. And then we'll look at ways to try to, minimize the adverse effects they're going to experience here, improve quality of life, etc. Right. So generally speaking, we're going to be using medications here. If they can't utilize non-pharmacologic therapy by themselves, then that's when we're going to introduce the medications here, which is seems pretty consistent with other things we've seen before. And the drug selection is going to be based off of the type of incontinence they have there, and then along with things like comorbidities that may be aggravated by the medications and things like that. So we'll go to our different treatment options here in just a few moments. Certainly from a non-pharmacologic standpoint here, we're going to see that this is going to be first line, obviously. We can do things like doing behavioral interventions, perhaps if, we can do things around like scheduling, urination, if we could do things like trying to do pelvic floor rehabilitation, things like that can be beneficial and avoid having to use medications and or surgery. And some patients just may prefer that. But if our meds or if our non-pharm stuff is not working, then we're going to switch over to the pharmacologic options here. Generally speaking, anticholinergics are going to be first line for urge urinary incontinence here. We have quite a few options that are available here. We have things like oxybutynin, tolterodine, trospium, sulfenacin, darafenacin, and then fesoterodine. A lot of these will end up coming in extended release preparations. We'll talk about why that's important in just a little bit. But they can come in XL formulations that will last throughout the day that can be good from like a compliance sort of standpoint there. And they're going to work by blocking the muscarinic receptors and will suppress that detrusor muscle contraction. So basically it's helping the bladder to store more urine before it gets that sensation that it needs to, or that stretch response that says, hey, you need to go to the bathroom. Any of these can be considered equally effective, and it's really going to be based off of things like what can the patient afford and what's available in a lot of cases there. As I mentioned, immediate release, long acting. The main difference here is that if you're looking from a compliance standpoint, long acting is preferred. You can also see if they are getting immediate release products are going to have a lot higher peak dose effects, which can lead to some of the anticholinergic side effects we're going to see here. Long acting typically has a much more sort of a gentle curve in terms of drug levels, and you see that the side effects are not going to be as quite intense. Because they're antimuscarinic drugs, they're going to cause anticholinergic side effects, right? So that's the thing where we talked about being dry as a bone, which is good in this case because it's helping them to prevent them from needing to urinate quite so often, but can also lead to things like constipation, dry mouth. You can see they're going to be, red as a beet, hot as a hair, or hot as a match, mad as a hatter. So these can be problematic in elderly patients because they can cause some mental status changes, especially. So, it's sometimes tough to tell whether their dementia is getting worse or some medications they're taking. So those are kind of the things you want to look at. You can see tachycardia associated with these, so just things to consider there. In terms of contraindications, if they have any conditions which are already causing urinary retention, this is going to make that worse, which hopefully you've ruled out in your patient there. If they have chronic constipation, this is not going to be a good set of drugs for them because that's going to slow down things even further. And then things like neuroangle glaucoma, you can see intraocular pressure increase here, and then myasthenia gravis that will worsen that since that's a condition where they have too little acetylcholine activity anyway, or transmission. So this would worsen that there. In addition to the mental status changes for the elderly, you can also see some increased risk for falls. So again, by using a long-acting formulation, that will help to prevent that to some degree, because you're not getting quite as big of a peak dose sort of effect there. So most common which you're going to run into, though, is going to be dry mouth or xerostomia. So that's going to be something your patients may be complaining about. But again, using long-acting preparations will help to mitigate that to some degree there. Just to point to a few of these, it has some unique points to them. With oxybutynin, this one does have some risk for orthostatic hypotension. One thing to note there, due to a little bit of alpha blockade activity that it has there. As I mentioned, the XL formulation is really first line in a lot of patients there because of the cost, the adverse effect profile. Generally, you can get it fairly cheaply. It's important to not crush or chew the formulation there, mainly because of the fact that with a lot of XL preparations, if you crush or chew them, that leads to it breaking the formulation and will release all the drug at one time. So typically, if you have a patient who has difficulty taking tablets and you want to prescribe them an XL formulation of a drug, make sure to look up and you can Google it, do not crush list. And that will give you a list of medications that should not be crushed or chewed, and make sure that the med that you're prescribing is not on that list. Some things can be, crushed or chewed if they're extended release. A lot of things cannot. So it's always good to double check that list whenever possible there. Tolterodine should not be used in patients with significant renal dysfunction or hepatic dysfunction there, mainly due to inability to clear it. And if they're on any sort of 3A4 inhibitors, that's something you'll want to avoid as well, or at least reduce the dose if possible. Trospium there, it's kind of interesting. It's more of a second generation sort of anticholinergic and helps to prevent some of the mental status changes that you see, mainly because of its chemical structure. It has this permanent positive charge. Basically, if you have a nitrogen with 4 bonds to it, which is called a quaternary ammonium, that can lead to that permanent positive charge and prevents the drug from crossing the blood-brain barrier. So kind of a neat little chemical alteration there that can help and prevent some of those side effects. This one has to be taken on an empty stomach because it has such poor bioavailability, and then should be also avoided in patients with renal dysfunction there. One thing you can also try, so if your anticholinergics don't really are not really working as well as you had intended, you can also do things like botulinum toxin. So this is Botox basically, not being used for its aesthetic purposes, but can be used for a variety of things. Like I think we mentioned it during the neuro talk with migraines, like tension headaches, it can be useful there. Here we can actually directly inject this into the bladder to cause it to be partially paralyzed, basically. Not the whole thing, because you still want it to be able to contract to some degree, but basically it's going to prevent the release of acetylcholine from the presynaptic neurons to prevent it from actually causing the constriction of the bladder to occur there. And this is more so used for like refractory cases of urge urinary incontinence, or especially like with those that have like a neurogenic sort of cause for it. It's off label, but something that can be done. And basically, this would be a procedure that the provider would have to do in order to inject into the detrusor muscle of the bladder itself. So again, it'd be something where they'd have to probably get like a surgery center appointment or something like that, or if they can do it in office, I'm not sure actually, but anyway, so this would be a whole procedure you have to do, and it's nice because the duration of action is pretty long, so between 4 and 8 months or so, and you just do this as needed. So if it starts to wear off and your patient's complaining of increased symptoms, then they can go back and do it again if need be. Obviously, because you're paralyzing this muscle here, you can see some issues in terms of things like urinary retention. Kind of makes sense. And like things like dysuria, hematuria, and UTIs are a little bit more common here, just because maybe you're not voiding as frequently. And so that would be one thing. So that's why it's not used as first line, and it's going to be more expensive than using something like an anticholinergic, typically, especially with like the procedure cost that goes into that as well. So in terms of urethral underactivity, things we can do include therapies to help with like closure of the urethra, or have increased closure pressures here, and estrogens can help out with this. Again, this is another sort of off-label sort of thing that may help some patients, more so those that are experiencing menopause and they're having that decrease in estrogen production, and this is thought to help with things like proliferation of the urethral epithelium. So you have more of that tissue there. They can help out with the closure pressure. Things like increasing the number and sensitivity of the alpha receptors that are there, all helping to have better closure, so that we don't have that leakage that occurs with that. We'll talk about the estrogen products pretty extensively here in just a little bit. So that's the next PowerPoint that's going to be coming up. But you can use things like vaginal creams. We can use oral products, transdermal products. There's quite a few that are out there. Progestins, which are kind of the other major sex hormone that we produce. So there's androgens obviously, but in terms of talking about estrogen, sort of the other half of that is progestin. They can actually have sort of an antagonistic effect. So we'll look at some of the details on that here in just a little bit. Typically, we would recommend the transdermal product for urinary incontinence, mainly due to it lacking some of the hepatic effects you're going to see with the estrogen-based products, including things like clots and whatnot. So again, just kind of that's a preview of what's coming up here in just a few minutes. In terms of things we can do to help out with that closure as well, we can use alpha agonists. We used to use a drug called phenylpropanolamine, which was a pure alpha agonist that would help with that closure there by activating those receptors, but it actually increased things like stroke risk, especially if hypertension, so it's not recommended anymore. So instead, what we can do is use duloxetine or Cymbalta, which is an SNRI, if you recall from our talk on behavioral health, and that helps out with increasing release of norepinephrine to cause basically more alpha-1 receptor activation, causing better closure there. So that's why it's thought to be used for that. And again, it can help out with other menopause symptoms and things like that. We'll see in just a little bit here. In terms of overflow incontinence, again, this is usually due to an obstruction sort of issue here. So you can kind of refer back to the BPH section where we're talking about things like alpha blockers, talking about things, if it's related to BPH, you can use things like 5-alpha reductase inhibitors, things like that. So it's pretty much the same treatment from that standpoint there. Yeah, and that's it for this section. Do you guys have any questions before I move on? Let's see questions on the board here. The last PowerPoint. Isn't that wild? We're done after next week. Who would have guessed? Been a long year, I can tell you that much. Not because of you guys, because of other stuff, COVID. Yeah. I know, woo. That is an appropriate response, I would say. Can't wait, I bet. Yeah, and then you guys are going to be on clinicals before you know it. Summer's going to go by super quick for you guys. But yeah, awesome. It's great. SUI is stress urinary incontinence. I'm trying to think. It sounds like some kind of like Law and Order. Law and Order, SUI. But I don't know. I couldn't think of any crime-related thing real quick there. Anyway, so this is our last section here. So we're talking about OB-GYN. So we're going to talk about pregnancy stuff first, and then getting into discussing hormone replacement and hormonal contraception, things like that. So that's what we're going to get into first. So pregnancy and lactation here. So talking about drug exposure and how it can affect developing fetuses. Okay. So checking, basically, when you have actual conception occur, you're going to see that, obviously we have our 3 trimesters typically, and the first one is really going to be the most sort of critical in terms of like organ development. So we have organogenesis. We're going to see that this is when drugs typically can have their most their biggest impact on the development of a fetus here. We're going to see that in some cases medications, actually depending on the stage of development of the fetus, you may find that medications may be okay in one stage of the pregnancy but totally not okay in other stages, and vice versa. So we're going to look at some cases of that and different how we can kind of determine like what's safe for a pregnant patient, what's not. I mentioned NSAIDs is a really good example of where the stage of pregnancy matters. So, for instance, early on in the pregnancy, first, second trimester, NSAIDs are actually okay for pregnant patients. But when you get towards the third trimester, it becomes more of a problem. We can talk about why that is here in just a little bit. Things like route of administration may affect how much fetal exposure you have, the dose and duration. And then what we can see in terms of the effects can be things like, destruction of the fetus, right? So you can have drugs that cause abortions to occur. We've looked at that before with certain prostaglandins like misoprostol. We can see things like CNS abnormalities, things like neural tube defects, things like that. So all kinds of problems can happen as a result of medications. And the question is like, well, how do we figure that out? You can't really do randomized controlled trials in pregnant patients and see what kind of birth defects you get. That would not be very ethical. So a lot of this is determined based off of either like case reports that come out, or if you're doing basically sort of interventional sort of studies to where you could look at maybe like retrospective studies of, a whole bunch of women who had exposure to this medication, saw what happened. That's how we kind of get that information there. We can also use animal studies, but obviously, what happens to a mouse might not be totally applicable to what happens to a human, obviously. So basically, a lot of the nomenclature around medications in pregnancy is traditionally been using the ABCDX category. No, I don't. I do know my alphabet. My kids are usually singing it most of the time. But that's the 5 categories we have of medications. And so nowadays we're starting to get away from that because we're going to find there's some limitations in terms of trying to put everything into 5 buckets. But a lot of people still use that nomenclature, so it's important to know, what it means. So starting off with A is very safe. I always like to think about things in terms of like, would I do this for my family member, or if my wife was pregnant? I hope that doesn't happen. But if my wife became pregnant, would she be okay to receive this drug? Would I be okay with her taking it? Things that fall into the A and B category, absolutely, totally fine, right? Either with A, we show that we have plenty of evidence from actual humans to say that, yeah, there's no real risk to the fetus there. Okay, so it's totally safe to use, at least with the evidence we have currently. With B, it's generally going to be that we don't have as strong of human evidence, or in the case of, we have maybe some animal evidence that does show harm, but based on the evidence we have in humans, it fails to show any issues. Yeah, Josh, I'm certainly glad you can commiserate on that. But anyway, points being is that, we don't have any evidence that it's going to be any harm to the fetus, but it's, pretty close to an A category there. So A or B, very safe to give, right? I'll go over C here in just a moment, but D and X are going to be the ones that you really do not want to give to any pregnant patients here. There are very few category D drugs, but it basically means there are some certain situations where the benefits to the mother outweigh the risk to the fetus, right? And so there's very rare situations where that occurs, but generally speaking, otherwise you don't want to give it to a pregnant patient because we do know that there are definite harm done to the fetus there. So a good example of this is something like warfarin. Warfarin being a vitamin K antagonist, fat-soluble vitamins are very important for developing fetuses. So anything that can block the activity of fat-soluble vitamins is going to be a no-go. So, generally speaking, warfarin is considered to be contraindicated in pregnancy unless you had something like the patient had a mechanical heart valve. Now, how many pregnant patients are going to run into that have a mechanical heart valve that need the anticoagulation? Very uncommon you're going to run into that. So again, but the thing is, it comes down to if you cannot keep the mom alive, then obviously the fetus is not going to stay alive either. So there are some rare situations. That's category D. Okay. Category X is going to be there's no situations in which the benefit to the mom outweighs the risk to the fetus. So you're thinking something like isotretinoin or Accutane for acne, right? The mom can deal with the acne for the duration of the pregnancy. It's not worth the destruction of the fetus, right? That's considered to be category X in that situation there. Now, C is kind of like the junk drawer. I'm sure most of you or maybe your parents have a junk drawer where like everything ends up in there, like different like old electronics and random stuff just ends up in the junk drawer. Kind of everything else that we don't really have good evidence to say whether it's an A or B or D or an X, everything just goes into category C. So basically it just says we don't really have enough evidence to say whether or not it's safe or not safe. So the problem with this is like almost everything gets put into category C because you can't ethically do studies on pregnant patients to figure out what category it falls into. So we basically have a lot of stuff that fell into category C, and it wasn't super useful for providers because they would say, well, can I use this drug on my patient? And they'd say, well, it's category C, so I don't know. It wasn't great from that standpoint there. So how things have been moving, and this is as of 2015, so it's been in use for some years now, is that we're trying to get more so into showing you the evidence of like why, what specifically have we seen in the evidence, the data that we have that may lead you to choose one or the other. And I'll show you an example of that. So if you're saying like the drawer where you put your empty iPhone box, never know when you might need it. I know my wife hates when I hoard electronics boxes and whatnot. But yeah, what if we move and I need to put my old iPhone into that box to move it to the new house where it'll stay there forever, right? Obviously. So anyway, so here's an example showing warfarin. So you can see here, it has the pregnancy category D. So otherwise, it's going to be an X if you don't have that, woman with the mechanical heart valve. But instead, what they can actually do is show you the actual considerations here. So the actual evidence that goes into deciding or showing you what has happened in pregnant patients who have received this drug, right? And they can also give you some guidance about maybe using alternatives, things like low molecular weight heparins, for instance, right? And there's also breastfeeding information to see if taking that medication while breastfeeding might affect the fetus, or not the fetus, but the infant at that point once they are breastfeeding there. Here's another example of ondansetron, which is considered category B. They say here, hey, listen, this is what we found. We've not found any evidence of direct harm to the fetus, etc. So and again, it's more difficult for the provider because, if you're working in a busy practice or the ER, for instance, you just want to know the letter. You just want to know, is it A or B, C, D, or X? But with this information, it does require more reading and actual, critical thinking. But it does provide you more info to decide, okay, is my patient, the one I'm dealing with right now, a good candidate for this drug or not? So that's kind of the way that things have been moving. So anyway, generally speaking, in pregnancy, you want to avoid medications wherever possible, mainly because if you can, prevent undue drug exposure to a developing fetus, because maybe there's something that only happens 1 in a billion. You don't want it to happen to your kid, right? So this is one of those things there where, generally speaking, if you can avoid meds, that's going to be good for most patients there. However, that's not realistic, right? So you may have patients that have chronic and acute conditions that occur during pregnancy. And so ideally, you'd like to be able to identify medication use prior to conception, right? So this is assuming your patient has the desire to become pregnant and is not pregnant yet. If you can eliminate non-essential medications, that's great. Discourage any self-medication, so make sure that the patient is talking to you prior to taking something. And then trying to minimize exposure to known harmful meds, whether it's by reducing the dose, changing the dosage form, etc. that can be sometimes useful, right, to help limit the amount of exposure to the fetus that is there. Note here that not every patient is going to know right away when conception occurs, right? It'd be nice if, the angels came down and said, hey, guess what, you're pregnant, or some big light went off or something. But a lot of times you can have inadvertent drug exposure to a fetus because the patient just doesn't know they're pregnant. That can happen for weeks or months potentially. So, in those cases there, if you can know beforehand, that's always great. If the patient's in a stage where they want to become pregnant, then you can try to do some of this beforehand, which is always ideal, right? So we're going to talk about some of the different pregnancy-induced conditions. Here we're going to talk about meds that might be more safe for your patients that are pregnant in terms of what we know with the evidence that we have so far. So we're going to get into all of these here. And we know there's a lot of physiologic changes that occur in pregnant patients. Some of these I'll touch upon as we get into it. First off, being nausea, vomiting. Everyone is familiar with morning sickness, I'm sure. Maybe not personally, but you've at least heard about it. This is something that happens in a lot of pregnant patients. This can be quite debilitating in some cases. Especially I know my wife in particular, she has a pretty sensitive sniffer in the first place. Her nose sense of smell is very good. It got particularly strong while pregnant, and she had certain smells that just triggered her nausea, vomiting, so we just had to make sure that none of those smells were in the house during that 9 to 10 months, but it can really be anything that can trigger this. And so if you can, try to do dietary changes. That could be one thing that can help out here. But in terms of medications, and kind of an interesting combo of drugs here, we have pyridoxine, which is vitamin B6, plus doxylamine. And doxylamine is an anticholinergic drug. It's an antihistamine, first-gen antihistamine that has anticholinergic properties, and is usually recommended for sleep. So it's Unisom is the OTC brand name for doxylamine. You can actually find the combo of the two there to be used specifically for pregnancy-related nausea, vomiting. It's called Diclegis. It's a delayed release product and is fairly expensive. So, if a patient could not afford that, you could always recommend just buying the over-the-counter pyridoxine doxylamine. You get generally the same effect. You just might need to take it more frequently, between 3 and 4 times a day, which is pretty frequent. Now, again, this is going to be sedating because of the doxylamine, so this is something to where, if the patient need to get up and go to work, this may not be the best med because it's going to make them kind of drowsy. Other anticholinergic drugs we can use as well include metoclopramide and promethazine. Obviously, those have some dopamine blocking capability, so you can see some Parkinson-like effects. Not ideal, but really we do have the 5-HT3 antagonist. We have Zofran you can use, which is considered to be a category B. Tend to be a little bit more expensive than the other options here, but if I had a patient who was not responding well to the pyridoxine and doxylamine, then probably I'd go with Zofran as a backup option there. As I mentioned, we don't have necessarily a ton of as much information on this as things like doxylamine and pyridoxine, but just because they're newer, we don't have as much evidence to show there. But not expected to cause any harm to the fetus. Not as much data on lactation either. So it's one of those things where typically after the birth, you should see a lot of that sort of resolve. But again, it's something you can look into the specific info on the monographs there. In terms of heartburn, with pregnancy, you can see as well as the fetus is developing, you can certainly see a lot of increased pressure, especially up on the diaphragm, leading to a lot of heartburn. And so one thing we can do is try to have more frequent small meals throughout the day. That can be useful. You can use antacids, but you want to avoid ones that contain sodium, mainly because you will see fluid retention, which swelling is a problem with a lot of pregnant patients, and then also you worry about their blood pressure as well. So and we'll talk about preeclampsia in just a little bit, but typically trying to minimize the amount of sodium they're intaking is going to be beneficial from a lot of standpoints there. But like calcium carbonate, totally fine. No big issue there. Carafate is fine to use as well. And then actually I should probably remove the ranitidine here because that is off the market. Sorry about that. But using H2 antagonists, those have been around forever and they've not really shown any issues in developing fetuses. So famotidine, totally fine to use for those patients there. PPIs, because they're newer, we don't have as much evidence. They're most likely very safe. So I would probably use that as a backup if the H2 blockers were not going to be effective. And again, H2 blockers you can get over the counter, relatively cheap compared to needing a prescription for the PPIs. So. In terms of constipation, if we can try to do things like increasing fiber and water in the diet, that can be useful there to help kind of increase the bulk of the stool and get them passed more easily. Some moderate exercise can be useful here, but for the most part, if we can use drugs that don't get absorbed, that helps to limit any exposure to the fetus. So things like bulk-forming laxatives are beneficial. Things like methylcellulose, psyllium husk. However, that could probably also exacerbate their heartburn if they're having any of that. Things like stool softeners can also be used. So docusate, it's still considered category C, but as far as I know, I've not seen any big issues with this in terms of use in pregnant patients. So it's, can be recommended in some cases there. And then nowadays, things like Miralax, which is over the counter, is more available, can be utilized there. So those osmotic laxatives. Things like lactulose, sorbitol. Most of the time, the patients are going to go with the Miralax since that's most commonly available. And then stimulants should be used occasionally, which apparently I can't not spell occasionally. Occasionally, I spell occasionally incorrect. But stimulants like Senna or bisacodyl can be used. But again, you don't want to use that chronically because then they kind of become dependent on having that around in order to have a bowel movement. Probably don't want to use things like mineral oil since that can actually decrease fat-soluble vitamin absorption. And again, as I mentioned, fetuses really need a lot of fat-soluble vitamins in order to have proper development of all sorts of different organs and whatnot. For hemorrhoids, best thing you can do here is try to prevent the constipation in the first place, since a lot of that straining tends to be the things that cause the hemorrhoids in the first place. Most of the topical products are okay to use because they are just working topically and don't have any sort of systemic absorption. So things like hydrocortisone works as an anti-inflammatory on those engorged sort of veins. Phenylephrine can act as a vasoconstrictor, totally fine there. And then Tux pads, which are made out of are using witch hazel, acts as an astringent, so it can sort of tighten up on that tissue and cause constriction of that blood vessel. So hopefully it's not going to be quite as large and causing as much pain there. And then things like sitz bats can also help as well. In terms of diarrhea, stool bulking agents here, like the psyllium husk and methylcellulose I mentioned before, are going to be preferred, with loperamide being used occasionally. Basically, that's working on those GI tract opioid receptors there to try to slow down peristalsis and things like that. So that can be used occasionally as in addition. So. Someone's asking, why would methylcellulose or psyllium worsen heartburn? Because again, imagine they're bulk forming, right? So they absorb a lot of water and whatnot, and so that can lead to sort of that feeling of fullness. I don't know if you guys have ever looked up like diet regimens and stuff that say, get lots of fiber because that helps out with not being hungry all the time. This is a case here where having that extra bulk could put additional pressure on things like the stomach and the diaphragm, can leading to the heartburn that can, and that's for some patients, might not be for all there. So that's why you can see that. Okay, so anyway, so moving on. Next, we have pregnancy-induced hypertension. This may be something the patient was dealing with. Yeah, see, Madeline. Sorry if I missed your message there, Madeline. Looking at pregnancy and related hypertension, this may be something why patients are maybe experiencing this before the pregnancy, but certainly can develop during. This is basically when we see the blood pressure rising up over 140, over 90, without any sort of proteinuria. That's considered to be gestational hypertension. Preeclampsia is going to typically be associated with actual proteinuria seen with that, so it'd be something you'd be monitoring the urine for. And you can see it, somewhat commonly, 6 to 8% of pregnancies there can develop that. And so once you develop severe preeclampsia, this is where you can start to see like some hepatic involvement. You can start to see a lot of protein spilling out into the urine, things like visual disturbances. That can lead all the way up into actual eclampsia, which is those tonic-clonic seizures associated with that pregnancy-induced hypertension, right? Could be life-threatening. So what we're going to do for these patients here is try to restrict activity, try to do stress reduction. For my wife, that was typically me just leaving the room, was pretty good stress reduction. DOC stands for Drug of Choice, or Department of Corrections, depending on the context there. But we're going to go with Drug of Choice here. Anyway, so things like exercise, mild exercise can help out with this to some degree. Keep in mind though, if patients are going to be on bed rest, this can be tough because you will see that there's an increase amount. Estrogen levels are going to be pretty high during pregnancy, and this causes the liver to produce more clotting factors, and so that could lead to potential risk for VTE. So that's a consideration to take there, which we'll talk about in just a little bit. Calcium has been shown to actually reduce the relative risk of hypertension and preeclampsia to some degree. So that may be, another reason why they should be taking their prenatal vitamins, because that can be useful. But if you wanted to have some additional calcium, that may be used in those cases there. And then the actual treatment of choice here, or the DOC, drug of choice, would be magnesium sulfate. And this is typically used for patients who are they're coming into the hospital, they're having severe preeclampsia, having actual eclamptic seizures. This is the drug of choice there. And so this is basically you're given pretty huge doses of magnesium. If you think about someone who's having like torsades, dose of magnesium there is like 2 grams, right? Here you're given between 4 and 6 grams, and then doing continuous infusion of 2 grams per hour afterwards. So just huge amounts of magnesium you're giving there, and it's kind of working as sort of a smooth muscle relaxant. That's why it's reducing that pressure there. So if you ever want to see the biggest doses of magnesium given, it's usually the OB floor is where you're going to be seeing that. Benzodiazepines and other anticonvulsants like phenytoin should actually be avoided because they can be teratogenic. So you do not want to do that for the fetus's sake. But magnesium, safe for the fetus. Again, this will help to drop that pressure and treat those eclamptic seizures the patients are having. Again, whenever a patient's having a seizure, you want to think about the reason why, and it may indicate that anti-epileptics are not the treatment for that patient. So if they're seizing because they're hypoglycemic, they need sugar. They don't need phenytoin, right? So you always want to look at the underlying cause for why they're having that seizure in the first place. Now, before they need the magnesium sulfate, because again, that's more of like something they would do in the hospital, we can try to do other things to manage that blood pressure. We have a couple of options. Kind of the old drug of choice used to be methyl-dopa, which was something that worked sort of like clonidine by activating those alpha-2 receptors and decreasing sympathetic outflow. That was good, but had some limitations in terms of side effects. Things like bradycardia, CNS depression, things like that. Other things we can use nowadays include things like labetalol, which is a 3rd-gen beta blocker, if you recall, that does have some alpha blocking capabilities in addition to blocking those beta receptors. In a lot of places, that's been used as the new treatment of choice, both on like an outpatient taking daily sort of basis, and also when they come in-house, you have IV formulations available as well, which is nice. Other things we could use potentially include some calcium channel blockers, namely your dihydropyridines can be used here. And then in really sort of rapid IV treatment, if you needed that, you could do something like nitroprusside or nitroglycerin to drop the pressure. If, say, for instance, the magnesium was not really cutting it, that could be an option there. We'll see the calcium channel blockers come up again just a little bit for some other purposes. So in some cases, they may be able to provide some dual benefit there. In terms of gestational diabetes, we're going to see here, this is again another thing that is always checked for. You're typically going to have women being screened around 24 to 28 weeks to see they get the dreaded OGTT, which is the oral glucose tolerance test. And it's been described to me as like drinking sickeningly sweet Kool-Aid. The stuff is just like super concentrated dextrose. And so they'll take that to see how are they processing that glucose. Can they process it correctly or not? Or do they have some degree of insulin resistance leading to elevated glucose levels there? And certainly you can have women who are already type 2 diabetic beforehand. You may have type 1 diabetes patients becoming pregnant. So again, these are all cases where you'd want to, any woman's going to be getting this OGTT done regardless, but especially if they have type 2 diabetes beforehand, they may be more likely to have this worsen during pregnancy. And usually you'll see this is happening in someone who had no history of diabetes. It'll resolve after the pregnancy, but they do have an increased risk for developing type 2 down the line for whatever reason. Dietary modification is generally going to be the first line thing here. So if you can limit, carbohydrate intake, that can be useful. And then if they need something to actually correct the glucose after they've done dietary modifications, then insulin is typically drug of choice. Insulin We produce it ourselves. It's very safe, and it's also it's a big protein, so it's not able to cross the placenta quite as easily as other things might. In the past, we've used things like glyburide and metformin, which we talked about previously. Metformin kind of working as an insulin sensitizer, whereas glyburide causing insulin release from the pancreas. Again, metformin seems to lack teratogenicity, so probably okay for most cases there. But if you can get it taken care of with dietary modification first, that's generally going to be preferred in a lot of cases there. And I think you're going to find when dealing with pregnant patients, or maybe if you've been pregnant yourself, I don't know, that the instinct for a lot of them is to not take anything whatsoever. So maybe even a challenge to try to convince them that, yeah, this med is safe. You can take it. It's not going to hurt your baby. Mainly because of things like that mommy guilt that they can experience. They worry about anything that they're doing during the pregnancy might affect the fetus down the line and when it's after it's born. So again, it can be dependent on the patient there, but in a lot of cases, most women are probably going to be more on the side of avoiding medications wherever possible if they can. There will be exceptions though, for sure. Let's see here. So then with thromboembolisms, as I mentioned, estrogen levels are pretty high during pregnancy. You're going to see that this can cause the liver to produce more clotting factors. And so this can be an issue in terms of causing VTE. So the risk is certainly elevated here. Can't use warfarin because that is definitely teratogenic to developing fetus here. And so in the past, or nowadays, we use things like low molecular weight heparins. Like enoxaparin is nice because you can use that, Q12, Q24, sub-Q injections. Unfractionated heparin has been used as well, but that's been, it has more frequent dosing associated with it, so we don't like that as much. The question of whether or not we can use the newer oral anticoagulants, I don't know. I don't know if the evidence is out there yet, but that'll be interesting to see if they can get away with that. That would be very beneficial from that standpoint. They could take something orally during the pregnancy. And then typically they get a minimum, if they've had a VTE during the pregnancy, they've got a total minimum of 3 months of treatment, and then generally for 6 weeks after the pregnancy. So whichever one, at least as long as they hit that minimum of 3 months, they'll continue it for at least that 6 weeks after. And that is when their hormone levels usually drop down to their baseline, essentially. David's asking, based on what we learned before, where would something like acarbose fit into the regimen? So we talked about that being potentially good for pregnant patients because it has very little systemic absorption, but also remember the side effects, causing a lot of flatulence, abdominal cramping, things like that. It'd be hard pressed to find a lot of people that want to take acarbose normally, but add that on top of pregnancy, and I think you'd find that be pretty intolerable. So it's good in theory, but in practice, I don't know if you'd find a lot of cases where it would be super useful. You could try it though. You can certainly try it, I think. Let's see. So why are type 2 diabetes meds not used to treat gestational diabetes? Again, we may not have as much evidence to show that a lot of these meds are as safe. So especially with like a lot of the newer ones, it's just really difficult in order to get enough information to make a good conclusion, right? A lot of the data that we have is sort of passively collected case studies, case reports that we're getting put in. There's certain adverse reaction monitoring programs that we're getting sort of passive information from. You just can't do a randomized controlled trial to figure out what the actual effects are going to be on the fetus there. Christine saying in the previous section said that treatments used for type 1 diabetes indicated for GDM. So for type 1 diabetes, that's going to be insulin. So that could be totally fine for those patients there. Again, insulin's not going to be able to cross up that placenta, so it's not really going to have much of an effect on the fetus. So insulin's totally fine for those patients for sure. So someone said here, aren't the sulfonylureas contraindicated in pregnancy because of them crossing placenta? I've not seen any like strict contraindications there. I think they've been used occasionally in the past, but it probably wouldn't be my first line choice there. There's some thoughts that it could cause depletion of insulin from the pancreas to the fetus, and so again, I would not recommend that in a lot of cases there unless they were like absolutely unable to be treated with really anything else. So that's kind of the big thing. And again, I wouldn't put you on a test question. I probably wouldn't ask you specifically, which of these meds would you use if a patient, refused metformin and insulin? and you had, dysphonia left, it's just, I just wouldn't recommend it in a lot of cases. It has been used in the past, so for sure. Okay. Some other things, so some treatment for acute conditions here include things like UTIs. So because of the risk for, the infection becoming more systemic, we always treat even if they're asymptomatic. So even if you have asymptomatic bacteriuria, we're going to treat that anyway. So we can do things like amoxicillin. Cephalosporins tend to be very safe for the most part, but however, you may see some resistance developing to those. And so another alternative we can use includes nitrofurantoin. Note that this doesn't cover Proteus if a patient is growing that, so it's going to be one hole in its coverage. Excuse me, and this is a medication that basically works to block carbohydrate metabolism in the bacterial cell wall, and you have to disrupt it from that standpoint. It's really only used for UTIs, because it collects in the urinary collection system and can treat those UTIs very well. It's not used for any sort of systemic infections. Any of these are fine as well with breastfeeding. So kind of have your pick here, depending on what they're growing in the urine. In terms of pain, typically acetaminophen is going to be the drug of choice here. It's recommended as the most safe out of the bunch. NSAIDs, though, because of their effect on prostaglandins, can be a bit of a problem in the third trimester. So one of the things you're going to see in the fetus is that their cardiovascular system is totally different than when they're born. One of the things they have is the ductus arteriosus, which is normally open in the fetal circulatory system. If you were to give someone, I'm sorry, the ductus arteriosus is kept open by prostaglandins, right? So once you're born, you'll start to stop prostaglandin production quite as much, and that will then close up naturally for most patients. What you can find though is if you give an NSAID in that third trimester, it can cause premature closure of that ductus arteriosus, and then you can disrupt that fetal blood flow through that, right? Because again, there's a lot of venous arterial mixing that happens through that. So that's why it's category D in the third trimester, but it's fine during the first and second trimester. And interestingly enough, we actually use NSAIDs in the NICU to try to chemically close the ductus arteriosus after they're born. So if they don't close off naturally, we can actually give them an NSAID, usually like IV ibuprofen or indomethacin, to try to close that off. And if that doesn't work, then they have to do like a surgical ligation. So kind of interesting how we can use that both for our benefit and for can be potentially harmful to the patient there. Now, opioids are actually safe to use in pregnancy. They're not going to cause any negative effects on the fetus there, but it is not recommended for long-term use, mainly because of the risk for things like, withdrawal that can happen in the baby once it's born, things like that. So certainly if you had someone who got into a car accident who's pregnant, they can get morphine, no problem. You just wouldn't want to use it chronically due to the tolerance and the physical withdrawal that can be experienced by the baby. Now, mental health during pregnancy is extremely important to consider. I think this is something in the past that it was not taken or not really thought about as much, or maybe not taken as seriously, but a lot of women may have pre-existing anxiety and depression and other mental health conditions, and certainly that does not go away just because you become pregnant, right? A lot of people will want to discontinue all medications, and that may not be feasible for some of them, right? So, because of that desire to not expose the fetus to anything, they'll say, okay, well, I was taking sertraline for depression, I'm just going to stop taking it cold turkey. That's not ideal in a lot of patients because, again, they still have anxiety and depression, so they still need to be managed there. And then, you talk about postpartum depression as well as being a big risk for some of these patients. And again, they're going through huge hormonal upheavals during pregnancy and afterwards where, things like estrogen and progesterone are going through the roof, and then they drop down precipitously, and that can certainly have an effect on mood as well. And so this is why it's important to be aware of it, to talk about it, to let patients know that this is normal when it occurs and it's okay to be treated, right? So I think nowadays it's starting to get better in terms of people being aware of the situation. Madeline's saying, is there a preference over morphine or Toradol in the acute setting, or is it just based on their pain level? Yeah, so if it was someone who was in the first or second trimester and it was, moderate pain, like an NSAID's fine, mild to moderate pain, I think an NSAID's fine. If they just broke their leg, like I'd still go with morphine. You probably use a combo of the two if they're early on in pregnancy. For that third trimester, though, I just avoid the NSAIDs altogether. You can certainly treat that pain with the opioids, no problem. Someone said, can you explain more on why opioids are safe in pregnancy? Yeah, so in terms of the development of the fetus, they don't have any effect on the fetus itself in terms of like actual development and growth and maturation. The problem you run into, though, is if patients are on it chronically, is that once the baby is born, if they've been exposed to opioids chronically, they get, they can have physical dependence on the opioid just like an adult can, right? So what you can run into is that you'll have patients who are using opioids, either prescription or otherwise, throughout the pregnancy, and then once the baby's born, they can experience something called neonatal abstinence syndrome, or NAS, and that is, pretty unfortunate for the baby. They experience a lot of difficulty in feeding. They're very very fussy, so they don't want to eat as much. They don't want to be, kind of there's difficult to manage, and so in some cases we actually have to put them on methadone and slowly wean them down. And so that's a very common reason why patients will stay in the NICU for longer than what they really need, is because of the fact they're having this neonatal abstinence syndrome. So they may be physically well enough to go home, but they're having this withdrawal, and so it's something to where you actually have to wean them down before they can really kind of fly on their own, so to speak. So in the acute term, opioids are fine. Chronically, though, it's going to be a problem for the baby once it's born, and they are being cut off from that opioid. If that makes sense. So anyway, so what can we do in terms of treatment? Typically, we're going to stick with our SSRIs. They have been shown to sort of be both effective and most safe out of the bunch here. We do know that there are some cases of things like cardiac malformations with paroxetine in general, so I probably wouldn't use that one. And there's also some risk you can actually see for withdrawal effects. So just like typical adult patients being treated for depression with SSRIs, if they come off of it cold turkey, they can have a lot of withdrawal effects from that. So they get anxious, they get they can they feel miserable, headache, things like that, nausea, vomiting. That can happen in the fetus too if they're cut off cold turkey. So this may be mitigated with breastfeeding, so that way they still at least have some some exposure. However, this may not always be the case. And I recall one time where I was on during my fellowship, we got called into the NICU, and it's very odd that you would have a tox consult in the NICU. It's just like, well, it's a NICU baby. There's no way they could have like gotten into a bottle of bleach or something like that. They don't even move practically. And so they're trying to figure out why this baby was so fussy, and they just could not figure out. The mom had denied opioid use. Mom, was opioid negative the whole pregnancy, and then we finally did, more investigation and found out the mom was taking an SSRI throughout the pregnancy, but because of whatever complication it was, the baby was in the NICU, so the baby was not breastfeeding. So all of a sudden, they went from having that chronic exposure to the SSRI to nothing, and so they were experiencing some withdrawal phenomenon. So we ended up having to treat that supportively. We didn't like give them like baby doses of sertraline or whatever it happened to be. But things like some low dose benzos might be useful in those situations there. Things like clonidine has been used as well for withdrawal symptoms in these babies. So we were able to get through that supportively. But again, knowing what it is what's useful, because we kind of ruled out a lot of the other kind of scary stuff that could have been. But anyway, so typically SSRIs are going to be preferred for these patients here. We don't like TCAs as much, mainly because of additional side effects that could be experienced by the adult patient. But we don't have anything, definitively saying there's problems going to be for the fetus with, your TCA. So it's more so because the adverse reaction profile is worse for the TCAs for the adults than it is for the SSRIs. That's kind of why we prefer that. And then folic acid, just as a kind of a last bit here, very important in terms of preventing neural tube defects. Honestly, the time to for these patients to get their folic acid is before the pregnancy has already occurred. Once you know you're pregnant, kind of if a neural tube defect is going to happen, it doesn't matter how much folic acid you take at that point, it's not going to do any help. But this is why it's so important for patients to supplement this, regardless of if they're pregnant or not. And actually, in the case of if you have a previous pregnancy that had a neural tube defect and they get pregnant again, or they want to get pregnant again, they would actually recommend taking like 4 milligrams of folic acid every day prior to conception, about a month or so prior to starting to try to conceive. The normal recommended amount is 400 micrograms. So you can see how big of a difference in the dose there is there. A lot of women don't follow this recommendation, which is why, again, this is just kind of a PSA just to say, hey, make sure your patients are taking their folic acid like they should. All right. So next, we can talk about our tocolytic therapy. So let's say we've gotten through the pregnancy. We're now at the stage where the loaf of bread is ready to come out of the oven. What are we going to do to help out with this? In some cases, we want to keep the bun in the oven for longer. Sometimes we want to get it out. There's things we can do for that in both directions there. So first off, we have tocolytic therapy. This is to try to prevent delivery of the baby too early. Okay, so if someone's having premature contractions, we want to try to help and prevent that. There's some medications we can do. Okay. First off, we're going to have our beta agonist. So this is something you could do potentially in the hospital, called terbutaline, which is very similar to albuterol. It's kind of in the same category there of being a beta 2 agonist. Similar to how albuterol relaxes smooth muscle in the respiratory tract, terbutaline can relax the smooth muscle in the uterus to prevent the contractions from occurring there. So that's one option. Magnesium has been thought to be used as well, mainly because it's acting as sort of a calcium channel, or not a calcium channel blocker, but sort of like a smooth muscle relaxant. So it's thought to have some benefit there. Although I don't know if there's enough evidence to recommend routine use. But you can also use something like your calcium channel blocker. So using a dihydropyridine has been efficacious, especially for like out of hospital use if they're at home trying to prevent contractions. Nifedipine can be used here, and that can be useful. Also, it can help out with blood pressure if that's also a concern for your patient. And then if you're concerned about hypotension, you don't want to cause that in your patient, something like an NSAID has been shown to be useful as well. So something like indomethacin has been used in the past there. So if someone was kind of borderline hypotensive at baseline and you didn't want to give them a calcium channel blocker, I'd say something like terbutaline or an NSAID like indomethacin might be an option there. Again, there could be risk with indomethacin because it's an NSAID, especially towards the third trimester. But again, you're kind of balancing the pros and cons there. Some said, are the withdrawal from SSRIs in neonates dose dependent? So less likely with a baby whose mom took 50 milligrams versus a mom who took 100 milligrams. I don't know that we have the evidence to say that is the case. I would, is there going to be an actual difference? I don't know. Logically, you would think that perhaps there would be one just because they're used to a bigger dose, so they're having a bigger drop off in the levels there. But I don't know if we have any clinical evidence to say if that is truly the case. It could be something to where the patient may want to reduce their dose while they're pregnant. I wouldn't do it necessarily from the withdrawal standpoint for the infant. But if it's something they want to do, try to limit as much exposure to the fetus as they can, then that might be an option there. So that's a good question though. I don't know. And trying to do the study would be nigh impossible because, again, infants and moms are difficult to do studies in from a ethical standpoint, as it should be. Another thing we can do as well, so calcium channel blocker is relaxing the smooth muscle of the uterus, basically. So just like it does on the vascular endothelium, it can do the same thing for the uterus. And so that's why we use the dihydropyridine specifically to relax that smooth muscle and allow for fewer contractions to occur there. In terms of things we can do to try to prevent the maturation of the cervix, so to try to prevent those changes there, because again, the last drugs we were looking at just relax the uterine smooth muscle. This is working specifically more so on the cervix. Is using progesterone. Typically, progesterone will help to prevent that sort of maturation to delay pregnancy, and so we can use something called 17-alpha hydroxyprogesterone. This is actually something given intramuscularly, and typically this is done in women who have high risk of preterm birth. So as an example, my sister actually, she gave birth to her first daughter at 33 weeks, and I believe it's 33, and then normally 38 to 40 is considered term. And so for her second pregnancy, she actually ended up getting put on this in order to try to prevent pregnancy, or prevent the labor from being from occurring. Interestingly enough, she had it almost to the same exact day. She actually had twins the second time around, so she had her baby's being born at 33 weeks, almost to the day as the first one. So I guess I don't know how effective it is based on my N of 1, but this is something that we can do for those high risk women. So nowadays it used to be like a custom compounded thing. You'd have to get like at a compound pharmacy, but now there's a commercial product available called McKenna, but obviously it's a lot more expensive than it used to be. But based on the regulations, you have to go with the commercial product if it's available due to good manufacturing practices and whatnot. So then in terms of labor induction, a few things we can do if we want to try to get things moving along in terms of labor. And so we have things that can help out with cervical ripening, and then also to help out with contractions of the uterus. So again, we have ways to do this kind of in both directions. We have some prostaglandin analogs that can be given to try to help with that cervical ripening, as I mentioned. We have dinoprostone, and then we have misoprostol, which we saw previously used in to try to prevent NSAID-induced ulcers. The dinoprostone is actually given vaginally, so you can insert it vaginally, and then once the labor begins, or if it's been 12 hours and still nothing's happening, then you would go ahead and remove it at that point. You can see some changes in fetal heart rate, so you're going to be monitoring for that anyway, so you're going to be checking that out. And then misoprostol, as I mentioned, can be used as an abortifacient if you use it like really early in the pregnancy, but here we can use it in order to actually cause the labor to occur, right? More expedient fashion. Something we can do to try to help out with constriction of the uterus, try to help out those contractions there, is actually giving oxytocin, which I'm sure most people are familiar with as being sort of like the love hormone. Like if you go and like hug your dog or your cat or your loved one, you release a whole bunch of oxytocin, right? And so we can use this exogenously. So the patient's going to be producing this themselves anyway, but we can give them an additional boost. And basically what you can see is that oxytocin receptors upregulate during pregnancy. And so we can go ahead and give them more of this to facilitate these uterine contractions. And so, in terms of adverse drug reactions, you can see some arrhythmia. Mainly PVCs are going to be seen there, so you're going to monitor them regardless. And then you can see some bleeding risk due to fibrinogen being dropped in terms of levels. Somewhat rare, but you could be monitoring for that if you notice any kind of bleeding, which, again, is a pretty common thing you're going to see after pregnancy anyway. So you just notice or trying to look for anything out of the normal. So, in terms of pain management during labor, this is where it's typically done with an epidural infusion, typically of a local anesthetic like bupivacaine plus an opioid like fentanyl. This is probably the most common combo. You may see like ropivacaine being used instead, but usually those two combination there. The benefit of using an epidural infusion is that depending on the level of the drug within the spinal column, that will affect where the anesthesia is going to occur. So if it's sitting down towards the bottom of the spinal column, it's really going to be affecting just the lower limbs, the lower part of the body. As it gets up higher and higher, that's going to be able to affect higher parts of the body itself. So, when you're thinking about someone who is in labor, you really just need to get them from basically like the diaphragm down, right? Because that's where all the pain's going to be, or predominantly like, in the lower half of the body. And so this is really interesting because how you position the patient can affect how high up the spinal column the drug is actually going to get. So if they're lying down, they're completely lying down flat, which you wouldn't see normally during labor, is that they would have effects pretty much all the way up through the body, which is not what you want, right? And the reason why we do it epidurally is because these drugs are not going to be affecting the fetus. It's going to stay right there in the CNS and not really be able to get out into any appreciable amount. So very effective at what it does, but also you can see that it can actually delay labor, because if you don't feel that baby, down below, causing all that pain and stretch, then you may not have as strong of an urge to push to get the baby out. And so in some cases there, you can try dialing your dose up or down, to make sure the patient's comfortable, but not so comfortable they don't even feel that they need to actually push. So it's kind of a give and take on that sort of thing there, a bit of a double-edged sword. You can see some hypotension with this as well. I recall when my wife was getting her epidural, I think for our first baby, I noticed her blood pressure was looking kind of marginal, and I was like, I don't know, maybe they're giving you a little bit too much of the epidural, and she says to me that she says if I could feel my legs, I would get up over and try to strangle you. So do not tell them to turn down the medication. And I said, yes, ma'am, and I proceeded to be quiet after that. So anyway, so those are kind of the things to look out for with an epidural anesthesia. Again, you can also see spinal headache associated with this, mainly due to the fact you're having to puncture the subarachnoid space. So that is something you can see afterwards as well. Okay, so it's 9:42, so I think I'm gonna go ahead and cut it here, since we have 70 more slides, or 80 more slides to go. And we can definitely cover that next week, so that'll be fine. So next week is our last meeting, so bittersweet, I'll say. How about that? Sad to see you guys go off and do your own thing, even though you're the first class I've never actually like seen in person, which is odd. But I will say for next time, if you guys have questions for the exam, try to collect those then, because I'll probably finish a little early, and we can talk about any issues you have in terms of the other material for the exam itself, right? And remember, it's going to cover geriatrics, endo, the nephro-uro section, and then OB-GYN. Okay, so that's going to be the whole test there. And yeah, if you have any other questions, though, certainly let me know now. I'll see anything. Otherwise, you guys are free to go. I hope you enjoy your weekend. Hope you have a great time, and then I'll see you all next week. I just wanted to see if you got my email. Well, I don't know who. That's funny because it's anonymous. I don't know who sent the email. I will check my email. How about that? All right, you guys have a good one. If you send me an email, I will try to respond to it. Okay, I will respond to you if need be. But okay. Yeah, you guys have a good one. I will see you all later.